afternoon. Welcome to the webinar on high flow nasal cannula therapy. Especially today, we are focusing on the use of high flow in patients with COVID-19, especially pediatric patients, our children. How do we use this important interventions as a life-saving measure in pediatric COVID-19 patients? So I would like to welcome you all who participate in this webinar. This is, I'm sure that all you agree that this is one of the need of an hour. So high flow nasal cannula therapy. Initially, at the beginning of this COVID-19 pandemic, the high flow is considered as one of the things we should not do. And most of the initial guidelines discourage the use of high flow because of this possibility of aerosol generation and the spread of infections. But while this pandemic is going on with the accumulation of evidence and use of this machine very safely, now the world has recognized that high flow nasal cannula therapy is one of the most important life-saving measure we can use in the management of patients with COVID-19. If we think about the history of this use of these high flow machines, actually most of these respiratory supports, ventilators and many of the ventilatory supporters developed in adult patients and adapted to pediatric patients. But this is one of the exceptions. Initially tested and practiced in pediatric patients, neonates initially, and then now being used in adult patients as well. So this is one of the major important interventions even now being used in adult patients in Sri Lanka as well. Unfortunately, we don't have much of the pediatric patients, children with COVID-19 who require respiratory support, but I'm sure that you have participated in our recent webinar also, as one of our colleague discussed. There are now children appearing with respiratory problems related to COVID-19. So more and more children might need this type of respiratory support. So the aim of this webinar is to share the knowledge, and this is organized by the Pediatric Intensive Care Chapter of the Sri Lanka College of Pediatricians. It's mainly Dr. Nalin Kitulwatha's effort with his team. So I would like to first invite our first speaker. So this webinar will compose of, as you already know, 2 presentations as well as 2 video demonstrations. So all are focusing to give some sort of insight to use this machine, very important life-saving measure in patients, so especially children with COVID-19. So it's my pleasure to introduce Dr. Deshan Adihetty. He is a consultant pediatric intensive. It's working in the Ledriji Hospital, the pediatric ICU of Ledriji Hospital. So Deshan will discuss about the physiology of these machines, why we can use this machine, as well as the important aspect of patient care while using this heated, humidified, high flow nasal cannula therapy. Over to Deshan.
Thank you, Chandna. So in this lecture, we are going to discuss about the physiology of high flow nasal cannula therapy. So objectives are to introduce you to the high flow nasal cannula system and to understand the mechanisms by which high flow therapy is working, discuss the indications, contraindications, and monitoring aspects and patient care. So the selection of cannula and the flow rates will be shown in the video. The high flow system, as you can see, is composed of several parts. So here you get the machine, which has a air blender. Air is sucked out from the environment, and also we have to supply oxygen-rich gas through the machine where it's blended, and then it's brought through the humidifier. So there is a sterile water that is supplied to the humidifier. And once it reaches the humidifier, this air is mixed with the hot gases, and then it's converted to the water vapor. The water is converted to vapor, and it mixed with oxygen, and then it's delivered to the specialized tubing system, which is heated. so that the water does not condense at the patient interface. So there are patient interfaces depending on the size of the patients, pediatric and adults and neonates. So the flow rates are from 2 liters to 60 liters per minute. So just to show you the clinical features of a high flow nasal oxygen system, basically it's an open delivery system which provides optimal humidity under optimal temperatures with high gas velocities. So open system means the nasal prongs only covers 50% of the nares. It's kept open for the mechanisms to work. And it provides optimal humidity and optimal temperatures, 37 degrees Celsius, so that the mucosa is not dried off, and it helps the mucociliary function and to prevent airway obstruction. Thirdly, the high velocity of gas flow. So if someone provides a face mask oxygen at 10 liters per minute with a high amount of oxygen, say 100%, under lab conditions, so up to 10 liters per minute, it is able to provide this amount of oxygen, 100%. But say you put this on a patient who has a greater work of breathing and greater oxygen air demand. So in that case, assume that the patient is developing and needing a peak flow of 30 liters per minute, then but we are providing only 10 liters per minute with this amount of oxygen. So the rest will be mixed with the air. So the patient will get only a mixture of this. As opposed in high flow nasal cannula, you can apply this gas at high flow levels. So assume we are giving at 30 liters per minute. So then the patient's demand is also, the peak flow is 30 liters per minute. Then the entire period you can get a higher fraction of inspired oxygen. So that is how the high flow device is going to provide you with a selected and higher amount of oxygen depending on the needs. And also the gas dynamics. So assume you are giving 6 liters per minute of gas flow with 45% oxygen to a pair of nasal prongs. And this will go to the nasal cavity and nasopharynx. And the patient is having oxygen peak flow rate of a demand of 20 liters per minute. So you are providing 6, patient is getting from his mouth also 20 liters per minute, so which is air. So then there is mixing. So ultimately the net the fraction of oxygen that is supplied will be less, towards 21%. Whereas when you apply a high flow device, which has a flow rate of 60 liters per minute with an FiO2 of 45%, so this region will have a high gas velocity. Whereas the patient is taking this additional 20 liters per minute through the mouth, that is from the air, but the mixing will be less and the fraction that is delivered is going to be higher. So, and the other thing I wanted to explain is, because of this high gas velocity, there is washing out of your carbon dioxide. So assume that 60 liters per minute, so is flowing with 45% oxygen, and during exhalation, what usually happens is the exhaled air will fill up your nasopharynx and the nasal cavity and comes to the nose. Majority will go through the nose and a little amount will come to the mouth. But when you apply this high flow, you can see that this entire space is going to be filled with oxygen-rich gas. So the dead space is going to be filled with this oxygen-rich gas. So during the next inspiration, you will be taking oxygen-rich gas instead of carbon dioxide-rich gases. At the same time, during expiration, because the flow rates are high here at the nasopharynx and the nasal cavity, majority of the expired gas will leave through your oral passage than going to the nasal passage. So there is less mixing, and the anatomical dead space is going to be replaced with oxygen-rich gases. So when we are talking about the evolution of high flow treatment systems, it was first described in 1993 in the New England Journal of Medicine, where a 51-year-old lady with pulmonary edema was rushed to the hospital, and she was at high speeds by their car, and she had noticed that it was initially difficult to breathe. Then she was peeping through the window. So whenever she got a high gas flow coming towards her, she noticed that it was easy for her to breathe. Whereas whenever the cars slowed down during traffic conditions, the difficulty of breathing worsened. So this was revealed once she recovered, and this led to further evaluation and development of the high flow nasal systems. So during high flow nasal therapy, people have measured the pharyngeal pressures with respect to the gas flows. They have found that whenever you increase the gas flow, your pharyngeal pressures will rise in a linear fashion. But this doesn't continue forever. As the patient's weight increases, the flow, the pharyngeal pressures tend to decline. So it is important. The other message that I should give you is, now this is your airway pressure, and this is the inspiration and expiration. So you can see during unsupported, unassisted breathing, during inspiration, there is a bit of a negative pressure. And during expiration, there's a small positive pressure. But with respiratory support with a high flow nasal system, the airway pressure has completely turned to a positive pressure. In inspiration, it is a minimum positive pressure, whereas in expiration, it's a huge positive pressure as per this graph. So this positive pharyngeal pressure is needed in order to reduce the work of breathing. So this is the end expiratory pressure in the pharynx with the flow per kg per minute. So as you can see, between this 2 liters per kg minute and 3 liters per kg minute, the end expiratory pressure is scattering around 4 water centimeters, that range. So that is how this 2 liters per kg prescription has been derived. Further going into the physiology based on this study by Chris Melisi et al. I can show you now. Pay your attention to this graph. So PP this is pharyngeal pressure, unsupported. You can see that it ranges between 0, minus during inspiration, and positive during expiration. Pharyngeal pressures supported with high flow therapy, it is completely positive pressure. In inspiration, there are dips, and in expiration, there is a further elevation of the positive pressure to around 5 watt centimeters. So at the same time, they had analyzed the esophageal pressure. Now in inspiration, you create a negative intrathoracic pressure. So this esophageal pressure was equivalent to the intrapleural pressures. And the amount, so you can see here, in inspiration, there is a pressure swing in the esophagus. It is from 0 water centimeters to a negative 40 centimeters water. But in supported by high flow nasal therapy, you can see this swing is less. During inspiration, the negativity is less. So they had derived a thing called the pressure time product, the time at which this negative pressure is going to last. So that is equal to the work of breathing. So as you can see, because of this positive pressure development in the pharynx, the work of breathing or the pressure time product has reduced. So that is how high flow therapy is going to reduce your work of breathing. So gas dynamics I had described. So it is an open system. So we need, so once you connect the high flow therapy to the nose, it's a high flow rate here. And the exhalation, because, and it washes off your anatomical dead space and as well as the carbon dioxide. And an open system is essentially important to maintain this pharyngeal pressure as well as the carbon dioxide exhalation. So impact of high flow nasal therapy. So it has drastically reduced the intubation rates in PICUs and the need for mechanical ventilation. Because mechanical ventilation is less, so the exposure to sedatives and analgesics and invasive procedures also has become less. So to summarize, it reduces your pharyngeal resistance, or provides some positive pressure in your pharynx, and it reduces your work of breathing, and it creates a carbon dioxide washout. What are the indications? So any respiratory condition, bronchiolitis, pneumonia, asthma, and cardiac conditions, heart failure. So it is also used for post-extubation care as well as for pre-intubation oxygenation. Contraindication for any airway obstruction, coronary atresia, any conditions where there is unstable airway due to neurological deterioration, and impending respiratory arrest and trauma to the adjacent structures, basal skull fractures. And also pulmonary airlick syndromes are considered as contraindication. So prescription-wise, you should prescribe the desired FiO2, which depends on the patient's pathology. The flow rate is 2 liters per kg per minute, and the temperature 37 Celsius. And you can choose the mode, pediatric or adult mode, depending on your clinical situation. So what should you observe once a patient is on high flow therapy? The vital parameters, the respiratory rate, heart rate, work of breathing, oxygen saturation, and the FiO2 requirements. So studies have been done as to how these parameters are going to change with time. It is said that the heart rate usually comes down by 10 minutes and the respiratory rate will take about 15 minutes to settle, and the oxygenation will improve by 15 minutes, and your supraclavicular retractions will take to settle about, it will take about 30 minutes for them to settle. So likewise, so these are studies, but these will depend on your patient's disease severity. So, but it gives us a clue that these parameters should be observed in order to see whether the patient is improving or not. So it should do. So going back to the slide, you can see that within 1 to 2 hours, most of the patients should settle. So when to escalate? If the patient is not settling by more than 2 hours, you have to think whether I need to escalate. Worsening of work of breathing, and in your blood gases, there's worsening of hypoxia or further rising carbon dioxide trend with an FiO2 requirement of more than 60%, you might consider escalation. So if a patient rapidly deteriorates, it's important to do chest X-ray and exclude pneumothorax. So this is an observation chart. So you can see that high flow therapy was started in these two groups, and this group can see clearly they are responding, respiratory rate versus time. The respiratory is coming down, whereas this patient is not responding. Same way in the heart rate. You can see that the heart rate was 165, 170 at the beginning, but with time, with 1 hour, it has come down to 145, likewise. So it's important to observe this pattern on your monitoring charts. I know in Sri Lankan monitoring charts, you go by the numbers. You don't see this graphical representation. So I think it's high time we change our monitoring so that we can see these patterns when you are monitoring patients. So weaning off from high flow therapy. So you have to give adequate time for the disease pathology to settle. Once the patient is showing signs of recovery, yes, you can come down on your FiO2. So once you come down on your FiO2 to 0.3 or 30%, then you can come off high flow. So we don't usually wean flow. Nursing care. Wise. So important thing is to check the nasal prong position and whether it's obstructed and whether it's creating pressure damage to the nares. Because these are we are talking about pediatrics, so children won't stay in one way. So these prongs can get dislodged and they can get blocked with secretion, especially in bronchiolitis patients. You have to look into that. Can I feed on high flow nasal therapy? Yes, you can. So first you should allow the patient to stabilize. So once the patient is stable, you can start on nasogastric feeds. And depending on the situation, you can increase it. If the patient is not tolerating nasogastric or orogastric feeds, should shift back to IV fluids, or if the condition is deteriorating. So another important point is whenever you are using high flow therapy, it's important to decompress the stomach with a nasogastric tube to prevent gaseous distension. So can I nebulize on high flow nasal therapy? Yes, you can. In this case, you should use a separate connector onto the humidifier. So this is a normal humidifier. In this situation, you have to use a separate adapter where there is a port for the nebulization chamber. And this is a very effective mode of nebulization. This is the gadget for nebulization. So this is the nebulization chamber that we use in our ICU. And the power source for the nebulization. So talking about high flow nasal oxygen therapy in COVID-19 situations, a study published in Chest 2020 September showed that applying a simple surgical mask onto the patient after the patient was connected to the high flow nasal cannula will reduce the droplet dispersion. So I think it's high time we start this practice, and it's important to prevent aerosol generation in the unit. And also it's shown to improve the oxygenation. So this is what I need to show you. So you have put the circuit as normal, then you have to apply this simple face mask. So take home messages. High flow is a bridging therapy. It can be a rescue therapy. It can be used in weaning as well. So once the patient is started on, the sick patient come, depending on the illness severity, you can choose either of these modes. So you can start on standard oxygen therapy, go to high flow therapy, and come back safely to standard therapy. Or some patients may not respond to this, and they will need escalation to the mechanical ventilation. But after extubation, still you can use high flow. So in weaning, it's important. So a lot of intubations have been avoided due to high flow nasal therapy. And it's a good mode of treatment. And the other thing is to use this face mask, especially on COVID patients when you are starting high flow nasal therapy. And the other message is the flow rate of 2 liters per kg per minute. It is needed for generation of these adequate pharyngeal pressures to reduce the work of breathing. I know there are lots of studies mentioned, but we practice this 2 liters per kg per minute, and this was also emphasized in the World Federation of Pediatric Intensive Care Societies sessions in 2016. So that is our current practice. Okay, so that comes to the end of this lecture. Thank you.
Thank you, Deshan, for that comprehensive count on the physiology of high flow nasal cannula therapy, as well as practically what are the implications of this new gadget. So I am sure that many of you, our participants, have already used these machines, but at least few of you have yet to use this important mode of respiratory support, as well as, even though some of you are using this, might have questions, some queries, how do we use this optimally? So next, we are showing a short video about how to select the how to set the machine, as well as how to select the appropriate nasal prompt. So can you play this video?
Before the Evo 2 humidifier can be used on a patient, you must ensure that it has been cleaned and disinfected. Check that the clean storage cover is sealed and its label is completed when you collect an Evo 2 humidifier from storage. Some hospitals leave the red disinfection tube in place instead of using the clean storage cover to indicate cleaning and disinfection has been carried out. Along with the Evo 2 humidifier, you will need the following accessories: an Evo tube and chamber kit, which contains an autofill water chamber, a chamber adapter, heated breathing tube, a bag of sterile water, and a patient interface. A number of interfaces are available for use with the Evo 2, including both an adult and junior nasal cannula, tracheostomy interface, and mask interface adapter. Please read the separate user instructions for the patient interface that are to be used, including all warnings. These accessories need to be replaced for every new patient. Prolonged treatment, replace the tube and chamber kit and adult interface every 14 days, and for junior interfaces every 7 days. Open the packaging of the tube and chamber kit. Remove the blue port caps from the chamber by pulling the tear tab upwards, then remove the bracket holding the water supply tube. Fit the supplied adapter over the two vertical ports on the chamber and push on fully. Then clip the water supply tube into position. Fit the water chamber to the unit by pushing down the finger guard and sliding the chamber on, carefully aligning with the blue chamber port ends. Push the chamber on firmly until the finger guard clicks into place. Attach the sterile water bag to the hanging bracket at least 20 centimeters above the unit and push the bag spike into the fitting at the bottom of the bag. Open the vent cap on the side of the bag spike. The chamber will now automatically fill to the required level and maintain that level until the water bag is empty. To ensure continual humidification, always ensure that the water chamber and/or water bag are not allowed to run out of water. Check that water flows into the chamber and is maintained below the maximum water level line. If the water level rises above the maximum water level line, replace the chamber immediately. Next, connect the heated breathing tube. One end of the heated breathing tube has a blue plastic sleeve. Lift the sleeve and slide the connector onto the unit. Push the sleeve down to lock. Choose the appropriate interface. The Evo 2 is now ready for the patient. With setup complete, the Evo 2 is now ready for your patient. The Evo 2's power cord should be well secured to the rear of the unit before plugging into the mains utility power socket. Switch on the Evo 2 by pressing and holding the on-off button for 5 seconds. The unit will show you whether it is safe for use on a new patient. A green light indicates that the Evo 2 has been disinfected correctly since it was last used. However, do not use the Evo 2 on a patient if the orange light appears. You must dispose of the consumables and reprocess this Evo 2 before it can be used. After confirming the Evo 2 has been correctly reprocessed, you will need to adjust the patient's settings to match the treatment required. The current values are displayed on the summary screen: dew point temperature, respiratory gas flow rate, and oxygen concentration. Each value will pulse until reaching its set point. To make an adjustment, press and release the mode button to cycle through the set point screens until you reach the desired option. Selecting the right dew point temperature will provide more comfortable and effective treatment for your patient. A dew point close to body temperature at 37 degrees Celsius is recommended, though you may like to reduce the dew point temperature if the patient complains that the gas temperature is too warm. Press and release the mode button repeatedly until the target dew point temperature is displayed. This padlock symbol indicates that the setting is locked to prevent accidental changes. Press and hold the up and down buttons for 3 seconds to unlock the setting. The lock will disappear and be replaced by an arrow showing the minimum and maximum accessible settings. Press and release the up or down button to choose the new setting. When you have finished, press and release the mode button to lock the setting again. The lock will reappear. After 10 seconds, the Evo will return to the summary screen. The current dew point temperature will pulse until it reaches the new target. The respiratory gas flow rate can be adjusted the same way. Press and release the mode button again, or wait 10 seconds to return to the summary screen. For patients that require oxygen as part of their treatment, you can connect the wall supply to the oxygen inlet port on the side of the unit now. Make sure you push the oxygen tube firmly onto this connection port. Be sure to read the oxygen warnings in the Evo 2 user manual before using oxygen. In particular, never have oxygen flowing through the unit when the Evo 2 is turned off. When changing the oxygen concentration, press and release the mode button repeatedly until the large oxygen view is displayed. Using a built-in oxygen sensor, the Evo 2 reports the concentration of oxygen in the respiratory gas flow as you adjust the flow on the wall supply. Simply adjust the oxygen flow until the desired oxygen concentration is displayed. While waiting for the unit to warm up, fit the appropriate interface, ensuring the head strap is not touching the ears. The Evo 2 can be used with a variety of patient interfaces. Read the separate user instructions for the patient interface that will be used, including all warnings. When the Ready for Use symbol appears on the display, connect the patient interface to the heated breathing tube. Attach the interface to the breathing tube by simply pushing the two connectors together until you hear a click. The gas delivered will feel warm when the patient first uses the unit. This is typical. They should simply continue to breathe normally. If the patient will be using an Optiflow Junior nasal cannula, you must activate Junior mode. Press and hold the mode button for 5 seconds until the Junior mode symbol appears. The Evo 2 will automatically adjust the dew point temperature and gas flow to safe limits for the Junior interface. The dew point temperature is limited to 34 degrees Celsius and the respiratory gas flow rate is limited to 25 litres per minute. To deactivate Junior mode, follow the same procedure. Hold the mode button for 5 seconds. As with any medical device, you may need to make adjustments to the Evo 2 as the patient's condition changes. Keep in mind that the patient's breathing pattern can affect the fraction of inspired oxygen. For this reason, you should always use a pulse oximeter and adjust the oxygen flow rate to maintain the appropriate blood oxygen saturation in your patient.
Fisher & Paykel Healthcare Optiflow Junior 2 is a nasal cannula specifically designed for the delicate anatomy and flow requirements of your smallest patients on nasal high-flow therapy. It uses new WaveFlex technology for enhanced prong retention and offers sizes to fit a wide range of patients while retaining the original benefits of Optiflow Junior. It's the next generation of care. Optiflow Junior 2 has 5 sizes in its range. Our newest extra small cannula released for the smallest of patients. The purpose of the in-service video is to explain how to correctly fit and use the Optiflow Junior 2 nasal cannula. This in-service video has been split into 3 parts: fitting cannula, removing cannula, replacing cannula. Important: before application of the cannula, follow your hospital protocol for skin preparation and gas source setup. Fitting the Optiflow Junior 2 cannula. Select appropriate cannula size. Recommended narrow occlusion is approximately 50%. Patient weight should only be used as a guide. The infant's nares should be the primary consideration. Choose appropriate cannula size. In this case, the patient is a medium. Before application of the cannula, follow your hospital protocol for skin preparation. The medium-sized cannula selected can now be removed from the packaging. Connect to the Fisher & Paykel Healthcare circuit. Check the connection by feeling the airflow through the prongs. The circuit can be secured to the bedding using the tubing clip. Remove the first backing tabs from the wiggle pads too, and avoid touching the adhesive. Keep the second backing tabs in place. Insert the cannula into the nares. Ensure the cannula bridge rests close to the nose without touching the septum. Do not stretch the cannula during application. Stick the wiggle pads too to the patient's cheeks. Remove the second backing tabs and stick the wiggle pads too onto the cheeks one at a time. Optiflow Junior 2 nasal cannula checks. Ensure the recommended narrow occlusion is approximately 50%. Ensure the cannula bridge rests close to the nose without touching the septum. Ensure the patient does not lie on the tubing, as this may apply pressure to the patient's ears or face. Check summary. Check 1. Size and space. Check 2. Sensitive septum. Check 3. Tidy tubing. Readjust if required. Removing the Optiflow Junior 2 cannula. Place fingertip on the outside edge of the wiggle pads 2, and gently peel the cannula away from the wiggle pads 2. Starting from the outside, peel towards the nose. Replacing the wiggle pads 2. Remove the Optiflow Junior 2 cannula. Use a damp cloth to wipe the patient's skin and the underside of the wiggle pads too, while gently peeling away from the patient's face. Adhere the replacement wiggle pads too to the cannula. Remove the first backing tabs and stick the wiggle pads too onto the patient's cheeks. Remove the second backing tabs and stick onto the patient's cheeks. Warning: appropriate patient monitoring, e.g. oxygen saturation, must be used at all times. Failure to monitor the patient, e.g. in the event of an interruption to gas flow, may result in serious harm or death. We hope you have enjoyed this in-service video on the Fisher & Paykel Healthcare Optiflow Junior 2 nasal cannula. Please contact your local representative for further information about these or any other Fisher & Paykel Healthcare products or therapies, or visit www.fphcare.com.
Okay. Next we have another lecture. As you know, the discussions about the use of this high flow mainly now currently going on alongside the increased surge of patients according to this so-called third wave of the COVID-19 pandemic. So as you know, there are many pediatric patients also appearing who requiring some sort of respiratory support, and high flow become the one of the major most important interventions as a life-saving measure, as Deshan mentioned, the bridging between the usual oxygen supply and the ventilation. So next, I would like to introduce Dr. Nalin Kitulwat, consultant pediatric intensivist of the Lady Ritchie Hospital and in charge of the medical intensive care unit of Lady Ritchie Hospital. I'm sure you do not need any introduction about him. He's the best board certified consultant pediatric intensivist, and obviously he's the flag bearer of specialized pediatric intensive care in Sri Lanka. So he's the founding president of the pediatric intensive care chapter of Sri Lanka College of Pediatricians. So he will discuss how this special modality of respiratory support could be used in children with COVID-19. Over to you, sir.
Thank you, Chandler. Good afternoon, everybody. So next lecture, we are going to discuss about place of high flow nasal prawns in pediatric COVID-19. So far, we have discussed the physiology and how important it as a bridging therapy in the management of respiratory failure in children. So this is how I'm going to do this lecture. Little bit about oxygen delivery devices and high flow nasal prawns. We have already heard about some of these things. And what do you mean by hypoxemic respiratory failure in COVID-19 and place of high flow nasal prawns, and the challenges, evidence, at the end, the recommendation, most important. So if you go through these are the common oxygen delivery devices that we are using. We have nasal prawns, face mask oxygen, venturi mask, non-rebreather mask, and high flow nasal prawns. And I want to highlight there are some the important parameters that we have to look for when you are using these oxygen delivery devices. Most importantly, the minimum flow. So the minimum flow is decided by some of the parameters, some of the physiological parameters when you're using these devices. So you can't go below this recommended minimum flows. Then the desired effect will not be there. For example, if you're using high flow nasal prawns, what we are recommending is 2 liters per kg per minute. So if you're using high flow nasal prawns below this recommended flow rate, the desired effects will not be there. So we have seen in our ICU also, sometimes you're getting patients from various other parts of the country. Children were on high flow nasal prawns for 10 days, sometimes 14 days, no response, about to intubate, and they are transferring here to LRH for the second opinion. So we see that sometimes they're using about 0.5 liters per kg per minute, very low when you comparing the proper flow of high flow nasal prawns. So we have seen very recently also one child came with this type of flow rate, and only thing that we have to do is to increase the flow rate to the proper dose, like 2 liters per kg per minute. Within 1 day, child improved. This is actually again post-COVID patient. So child improved and we have discharged the patient. So this is about the high flow nasal prawns. As Deshan clearly mentioned, there's a flow meter, oxygen blender, humidifier, and the patient interface. And 2 important aspects, Deshan already discussed these things, but I think it's important to revisit it. So when you're using nasal cannula, this dead space is not washed out. But in high flow nasal cannula, the high flow nasal prawns therapy, since you're using a high flow, this dead space is washed out. So this is very important when you're thinking about the carbon dioxide removal. So carbon dioxide washout in high flow nasal prawns, the flow dependent carbon dioxide clearance, obviously. So it reduces the anatomical dead space, improves the work of breathing, lowers the respiratory rate. That's all what we need when you're using high flow nasal prawns. And achieving high flow is critical to maximize carbon dioxide washout. That's why we say not to reduce the flow rate. And then the second important aspect is room air entrainment. When you're using nasal cannula, room air can entrain into the amount of air coming to the nasal passage. So oxygen dilution can happen. But in high flow nasal prawns, again, since we are using very high flow, the room air entrainment is less. So you can get the greater oxygen delivery. For example, so in quiet breathing in adult, what they say is they need about 30 liters per minute. So if you are not supplying these 30 liters per minute from the oxygen delivery device, invariably part of it is from room air. So in respiratory distress, in adult, this can go up to 100 liters per minute. You can see even the maximum amount of high flow nasal prawns cannot supply this. So that is why it is important to use maximum flow rate in high flow. So again, just to highlight this, alveolar oxygen delivery will depend on oxygen flow rate, FiO2, devices interface, and inspiratory demand. So as I explained, quiet breathing adult, it's about 30 liters. Respiratory distress in adult in 100 liters. So obviously, when you are delivering this flow rate, flow rate should be more than demand. Then only we can get the optimum delivery and the optimum care for the patient. So achieving high flow is critical to minimize room air entrainment. So that is why we are highlighting. We know there are so many guidelines. We know there are so many countries using various guidelines. But when you read the literature and when you are going for the international the discussions about high flow, what they are emphasizing, we have to use 2 liters per kg. When the goal is to prevent intubation, it is desirable to target the highest flow to reduce work of breathing while separately titrating FiO2 to achieve the desired saturation. So if you want to prevent intubation, so you have to target the highest flow. This was clearly mentioned in high flow nasal cannula oxygen in adults and evidence-based assessment. This is Annals of American Thoracic Society. So it's very clear, if you want to use high flow, use 2 liters per kg. So our goal is to prevent intubation. So use 2 liters per kg per minute. Maximum is 60 liters per minute, no half doses. Right, so these are the benefits of high flow. So already we have discussed these things. I'm just highlighting that improves oxygenation, decrease anatomical dead space, decrease metabolic cost of breathing, reduce carbon dioxide generation, and generation of positive nasopharyngeal and tracheal airway pressure, improved work of breathing, preconditioning of inspired gas, that means heated and humidified, better secretion clearance, superior comfort, and reduce room air entrainment. So all these things are happening with high flow. Right, so if you think about the COVID-19 pneumonia in children, that is why we need this type of devices. It is rare. COVID-19 pneumonia in children is rare. So we had largest COVID-19 retrospective case review. This was in 2,143 children. 4.4% were asymptomatic, 50.9% were mild symptomatic, and 38.8% were moderate to mild symptoms. The pneumonia with fever and dry cough, but no hypoxemia, so without hypoxemia. So severe symptoms only has had in 5.9%. So COVID-19 pneumonia in children is rare. But since this is a new disease, just 1.5 years, evidence is changing. We need to update every day, and decisions should be taken depending on the most recent evidence. So these things may be changing. The numbers may be changing with time. So we have to be prepared to whatever the condition that we are faced to. So there are 3 phenotypes of lung disease, lung damage in COVID. What they say is, yes, L type, H type, and F type. What is happening in L type, what they are explaining is, it's basically the compliance is better. It's called the interstitial pneumonia. Compliance is better, but the patient is in respiratory distress. This is called L, is low fluid in lung. The second phenotype is H type. Then it's called the H because fluid level or fluid amount in lung is high. So this is basically the classical ARDS. So this is not classical ARDS. Usually in ARDS, compliance will be low, but in classical ARDS, compliance will be reduced. And the third one is F phenotype, that is fibrosis. So later, this lung tissues will be replaced by fibrous tissue. So that is why it's called fibrosis. And this, the second part, the phenotype H or high fluid level, low compliance lung disease is called due to the SILI. This is called self-inflicted lung injury. So why there's a self-inflicted lung injury? Because the patients are having respiratory distress, they're having rapid breathing. So because of this rapid breathing, lung is getting damaged. So that is why the main reason for this changing from this L type to H type. So can we stop progression? This is the COVID. Because of the virus we are having a little bit of pneumonia. So initially the compliance is better. So, but since they're hypoxemic, their respiratory rate is high. So they are trying to increase the rate. So that causes self-inflicted lung injury. So can we stop there? Still we don't know, but whole emphasis is on that. All the oxygen delivery devices, what you're using is to prevent this. If you can prevent the respiratory distress, if you can prevent the respiratory rate in these children, whether we can change transition from this to this, transition from L to H, that's the key. Right, so initial guidelines of COVID-19 pneumonia. So they have advocated to intubate with rapid sequence induction, because one thing is to avoid unanticipated intubations, because we see now we are not intubating. So at last moment, if you want to intubate, so then there are very important two risk factors. One thing is it's very high risk for the healthcare worker because you're not ready, you're not put on the PPEs. So it's very high risk of healthcare workers. And not only that, even for the patient, very high risk for respiratory arrest because people are not ready. It will take time for them to ready. So that is why initially they advocated to intubate as early as possible with rapid sequence induction. Second thing is, the second consideration was non-invasive ventilation. All the modes of non-invasive ventilation had high aerosol generation. So again, high risk for healthcare workers. But with time, we realized that invasive ventilation in COVID-19 pneumonia had high mortality. It's very difficult to extubate. We had our experience also. We had about 8 pneumonia patients with the first and second waves. The 4 died. So initially we have intubated. So then we realized that intubation is not the way to manage these patients. So that is why high flow nasal cannula or high flow nasal prawns may be a good alternative. Then some hospitals discourage high flow nasal prawns. Their worry was, one is aerosol dispersion, because we know that these type of devices can generate aerosols. So with this, whether we can get diseases, we can get the COVID-19 from patient to the healthcare worker. So healthcare worker at increased risk. So then there are so many studies. This was published European Respiratory Journal into the last year. So these are the devices. These are the oxygen delivery devices, and with these flow rates, this is the distance of dispersion of the particle. You can see it's about 17 centimeters for high flow nasal prawns with 60 liters of minute, and all the others are high. So 13 here and 11 to 9. So basically there's not much of a difference. If you think about the Venturi mask, and so it's about 39. So there's not much of a difference if you think about the other oxygen delivery devices. Then people see, okay, if you can put a simple surgical mask over the high flow nasal oxygen cannula, it shows that it will reduce the exhaled air dispersion. And not only that, that will improve the COVID-19 patient's oxygenation. So we'll go to the little bit of studies on that. So you can see, so this is high flow nasal prawns with mask. This is high flow nasal prawns without mask. Low flow nasal cannula, this is basically nasal prawns with mask, without mask. And no therapy with mask, without mask. You can see that if you are not using the surgical mask, there will be greater dispersion of the particles. So obviously that helps. And not only that, this study showed if you put a surgical mask over high flow nasal prawns, they will improve the PaO2. You can see this is without mask, this is with mask, without mask, with mask. So PaO2 has improved, PF ratio, PaO2 FiO2 ratio has improved, saturation has improved, PaCO2 clearance also has improved. So respiratory parameters with high flow nasal prawns alone and high flow nasal prawns plus surgical mask, improvement in all variables. So that is why now it is clearly recommended put a simple surgical mask over the high flow nasal cannula so that it will improve all these things. What about high flow nasal prawns versus traditional ventilation in COVID-19? So they have done a study. So common pool, this is early intubation, this is with high flow. So similar numbers. What we are saying is ventilator free days are more on high flows. Intensive care unit length of stay is less in high flow, and in-hospital mortality is less in high flow. Again, it's clearly demonstrated that high flow is better than invasive ventilation in the management of COVID-19. The next problem is that most of the people are asking high flow nasal prawns whether it's using a very high flows, is it oxygen killer? Obviously, you see 60 liters per minute. If you want 100% FiO2, you have to do 60 liters. But if you want only 50% FiO2, that you want to use only 30 liters. So it's not only the oxygen. So it's the flow that matters. And with all the parameters that we have discussed, we have seen the mechanism of action, and 100% is not always needed. It's not only oxygen. And early de-escalation is possible with high flow nasal prawns and can prevent ventilation. Outcome is better than IPV. So initially years, if they need, we have to use a high amount of oxygen, but with time, if you think about the whole patient, it will definitely reduce the amount of oxygen, amount of care, and the life from the patient. So that is important. So the evidence so far says better patient compliance, improve oxygenation, lower intubation rate, lower mortality rate, non-inferior to NIV in re-intubation, and better than IPPV. So that is why we should use this thing. There are some recommendations. The WHO guidelines advocate for high flow nasal prawns prior to intubation in the overall plan of management. The Surviving Sepsis campaign guidelines also recommend the high flow nasal cannula over non-invasive ventilation during conventional oxygen therapy failure in COVID-19 patient. So a lot of guidelines recommending high flow nasal prawns, some are not, but if you go through, most of them are recommending high flow nasal prawns in the management of COVID-19. So ventilation guidelines in adult with COVID-19. So start with oxygen if saturation is less than 90. Target is 94 to 96. Start with conventional therapy. If fails, go for high flow nasal prawns. High flow is better than NIV. That's why we are starting with high flow. And if high flow is not available, if you're having a non-invasive ventilation, go for it. And close monitoring and early intubation in a control setting if worsening. So that is the most important part. Whatever the method that you're using for oxygenation, the important thing is close monitoring, because the emergency intubation causes the worst outcome for the patient as well as the healthcare worker. So early intubation in the control settings if worsening. So to do this, you need close monitoring. So this was suggested in the European Society of Intensive Care Medicine and the Society of Critical Care Medicine last year. So again, just to summarize the general schema. So if the child is deteriorating, high flow, invasive mechanical ventilation, prone, if possible, ECMO. And if the child is recovering, again, de-escalation should be the same way. So escalation and de-escalation should be done according to the patient's parameter. So in summary, high flow nasal prawns in COVID-19 is simple and safe to apply. Patients are comfortable because they keep high flow nasal prawns in place than NIV. You know how difficult to keep NIV mask over the patients or children's face, but they're tolerating this, the high flow nasal prawns. So that itself will reduce the number of visits into the room. If they're keeping the nasal prawns without any fussing, you can just allow without going in. So you can monitor the patient. So if they're changing, if you are removing the non-invasive ventilation mask, so if somebody has to go in. So that itself is an added advantage when you are managing COVID-19 patient. But the pitfall. So if you put a high flow nasal prawns on unstable or severely hypoxemic patients, and if you are not monitoring them adequately, definitely you may go for emergency intubation. So as I explained earlier, it's very high risk for the aerosol generating procedure. So very high risk for exposure. So healthcare workers are get exposed, and not only that, it's increased mortality and morbidity for the patient. So it's very important, put them on high flow nasal prawns, but monitor them adequately and clearly. Just any query, if you think the child is deteriorating, go for intubation in a controlled setting. So in summary, start with nasal prawns oxygen, escalate depending on the condition. If the child is having distress, rather than going one by one, go directly for the high flow nasal prawns, because that itself shows some PEEP effect, and that will help the respiratory stress. And the target oxygen saturation is 94 to 96. De-escalate depending on the condition, and very, very importantly, close monitoring. If you have deterioration at any point, early control intubation. So that's the key in the management. So this is our unit at LRH. So we have one-to-one care. All the COVID positive patients are managed by one nurse in the bedside, like any other patient. All needy procedures are done, even aerosol generating, nebulization, high flow nasal prawns, intubation, high frequency oscillation, IC tube, PD, resuscitation, all of them are done without any change, any difference from the non-COVID patient. Okay, is similar to any other child, but with full PPE. The important thing I want to mention, I want to highlight is that none of the staff have got the infection from the patient. So if you are using full PPE, you can do whatever the procedure without getting the infection. Thank you very much.
Thank you, sir. Again, you have heard comprehensive account on the use of this technique in children with COVID-19. So one thing we have to stress that is, as Dr. Gitulata correctly mentioned, so this is high flow nasal cannula or nasal prong therapy. This is sometimes now the term has little bit changed. It's high flow nasal cannula oxygen, but it's not the oxygen. It's the mainly the flow is the most important thing. Depending on the situations, we may adjust oxygen. So that's why it's very important. And most of the time, if we use it correctly, we can even save oxygen. So it's high flow. Flow is the most important thing. So then when you are using this machine, you might already face some of the technical issues, troubleshooting, or if you are about to start this therapy, you might face some of the practical issues. So next, we have a video to show the troubleshooting and other thing is most importantly the disinfection of these machines. How do we disinfect before using another patient? Shall we start the video?
The Evo 2 must be cleaned and disinfected between patients. This should take place as soon as possible after use. The reprocessing steps can be found in the disinfection manual or on the swing tag. These steps must be carried out between patients: cleaning, high-level disinfection, and storage. Cleaning is particularly important. You need to remove debris so that disinfection works effectively. It's easiest if you leave the Evo 2 on the mobile pole stand. Switch off the unit and unplug from the mains utility power socket. Remove the breathing tube, water chamber and water bag and safely dispose of them. For cleaning, you will need a cleaning sponge stick, approved cleaning wipes, a clean, damp, lint-free cloth, and an approved cleaning solution. Follow the manufacturer's instructions when using any cleaning solution, diluting it if necessary before use. Avoid toxic, abrasive or corrosive cleaners that may damage the Evo 2. The disinfection manual or your local Fisher & Paykel office can provide advice on appropriate cleaning products. The most important part to clean is the outlet elbow between the right chamber port and breathing tube port. Do not clean the left-hand chamber port, as this can damage the non-return valve located at this port. First, dip the cleaning sponge stick in a solution of warm water and mild detergent. Thoroughly clean the outlet elbow from both ends as far as possible, continuously rotating the sponge stick. Rinse the cleaning sponge stick under running water and using the same rotation action, remove any residue from the outlet elbow. Discard the cleaning sponge stick. If using a disposable cloth, thoroughly clean the outlet elbow from both ends as far as possible, continuously rotating the cloth with your finger. Use an alcohol wipe or apply an alcohol solution to a clean, damp, disposable lint-free cloth to wipe the outside surfaces of the unit. The next step is high-level disinfection using the red disinfection tube. This process heats the outlet elbow to at least 87 degrees Celsius for more than 30 minutes. Minimize the risk of cross-contamination by starting the disinfection cycle immediately after cleaning. First, connect the red disinfection tube to the Evo 2. One end of the disinfection tube has a blue plastic connector. Lift the sleeve and slide the connector onto the unit. Push the sleeve down to lock. Connect the red end of the disinfection tube to the left-hand chamber port and push fully into position. Then fix the blue filter cap securely onto the right chamber port. The Evo 2 is ready for disinfection. Connect the power cable to the mains utility power socket and start the disinfection cycle by holding the on-off button for 3 seconds until the unit beeps. The Evo 2 will turn on and run a series of calibration checks, raising an alarm if any problems are detected. For example, you may be prompted to change the air filter. If so, remove the filter cover from the back of the Evo 2, discard the old filter and insert a new one. Make sure the filter cover is properly attached. Once everything checks out, the disinfection cycle will begin. It will take 55 minutes to complete, and the display will count down the time remaining. If any problems arise during disinfection, start the cycle again. If the problem persists, refer to the disinfection manual for more information. Once the countdown reaches 0, the disinfection cycle has completed successfully and the disinfection number is displayed. Finally, turn the Evo 2 off by holding down the power button. Disinfection is complete. You can remove the disinfection tube at this stage and seal the Evo 2 with a clean storage cover. If you are not using the clean storage cover, you may prefer to leave the disinfection tube in place for storage. In either case, it is best to leave the Evo 2 on the stand to protect it from bumps and knocks. Write your name, the disinfection date and the disinfection number on the space provided on the clean storage cover. Store the unit and disinfection kit in an area suitable for medical devices, which is clean, dry and dust-free. Never store the unit until it has been cleaned and disinfected. The Evo 2 is now ready for the next patient. The Evo 2 has been designed to be as reliable as possible and will automatically raise an alarm when a problem is detected. The cause of the alarm is shown on the display. Silence the alarm with the mute button. In this example, the alarm was raised because a blockage has been detected. Once the blockage has been found and corrected, the Evo 2 will continue delivering therapy to the patient.
Thank you. So next might be the most important part, the Q&A sessions. I'm sure you might have some questions or queries to be clarified with our panel of two consultant pediatric intensivists. You can use this chat option or even Q&A options. You can type the questions and send to the panel so I can moderate this. Before going to the questions about technical things, one of our senior pediatrician has raised a question. Deshan might answer. All the videos I'm sure had formed before the COVID era. So can you just update about the use of the disinfections and the use of these machines? How do we adapt during this COVID era?
Chan, I couldn't hear your question. Sorry.
I couldn't hear. No, this. Can you hear now?
Yeah.
Yeah, so one of our senior pediatrician has raised this issue. I am sure these videos has been formed before the COVID era, and he has raised that when we are disinfecting these machines, so we have to use PPEs and other protective measures. So we want to update or give some update about that.
Yeah, so once the machine has been used, I think it's safe practice to do the disinfection process with personal protective equipment, especially the double masking, the mask, the N95 with the face shield, and the head cover, the cap, and the gowns. Because we are still new to this disease and we haven't got any studies with regard to infections from cleaning equipment, but it's better to be careful, I think. And so I think it should be done in a manner with standard personal protective equipment.
Okay, thank you, Deshan. And sir, want to add anything?
Yeah, I think it's been happening. It's happening in LRH at the moment. So we are disinfecting the people who are disinfecting these the devices are using full PPE.
Yes, thank you. And yeah, next question is anyway to you. This L-type and H-type, so it's a new disease, new concept. There are a lot of controversies and issues about these pathological changes. One of our attendees asked that, is it the rapid respiratory rate to high tidal volume ventilation that cause change of L to H-type?
Yeah, so still we are in this is a new disease. So the studies are very minimum. So this was done actually by Gattolani. He's one of the world famous authority on ARDS. So they have done a series of CT scans on these patients. So what they have found is these three phenotypes of lung damage. But we don't know really whether this rapid breathing or high tidal volume causing the first phenotype to second phenotype. But the danger is if you start the L to H, that means we have started this journey. So the important thing is whatever the measures that if you can prevent this from L to H, we have to adopt that. That's what I want to highlight, because all the devices, oxygen delivery devices, the delivering some of the CPAP CPAP effect. So they will improve the lung and they will improve the oxygenation, so that we hope at the moment we can prevent from L to H. Still, we don't know, because it's a new disease. We don't know how to prevent this, but people are doing a lot of studies. So only thing is that we are thinking, how can we do that?
There are a lot of issues regarding this oxygen supply. I am sure this is the era with even the general public has started to discuss about the oxygen. So there are still some of the practices that we practice might not be accurate, especially providing oxygen supply, especially oxygen providing special different methods. As you mentioned, there are guidelines and especially this minimum oxygen requirement when we are using various types of oxygen delivery devices. So one of our pediatricians asked that does the minimal flow rate of nasal prongs in infants also apply to non-COVID conditions? And when we are tailing off, does it also apply with the tailing off oxygen, like in preterm babies?
Yeah, again, these are the guidance given by the various guidelines. So that these are the minimum oxygen flow rate that we are using this type of devices we should use. Some of these actually having a physiological basis. Like if you think about the non-rebreathing mask, if you are using less flow rate, definitely this non-rebreathing effect may not be there. But at the same time, these nasal prongs is the last one, the least the sophisticated method. There's no such physiological basis behind it. But I think if you are trying to reduce the flow, because now we are using about 50% of the nares, so child may not be able to breathe properly. So that what they're telling is, rather than giving less than the recommended oxygen, it's better to remove this and give oxygen with some other menu. So there's no physiological basis if you discuss about the nasal prongs, but other places, yes.
Yes, thank you. And so one of our, again, senior pediatricians asked about this. You mentioned about the lung damage, and this 100% oxygen can also further damage the lung. What do you think about that?
Yeah, definitely yes. Because now this lung damage is the lung problem in COVID is two aspects are there. One is the hypoxemia. Second one is the carbon dioxide retention and low compliance. So importantly, what is important is we have to keep the saturation, because all the other organs need oxygen supply to survive. So we want to maintain the saturation. At the same time, use minimum of FiO2, minimum of oxygen, rather than using 100% FiO2. So that's the importance of using this type of high flow machines, because they can provide not only oxygen, they will improve they are removing the carbon dioxide. At the same time, there's some CPAP effect, so that the surface area available for gas exchange will improve, so that even with the low FiO2, you can increase the saturation. So that's the aim. So that is why it's more important to use high flow machines rather than the traditional delivering devices.
Exactly. So the flow is the most important initial part to wash out the dead space, as well as providing some oxygen supply, as well as you mentioned, providing some pee. And you have strongly recommend the use of this 2 liters per minute this to maintain the adequate supply, prevent further deterioration. So that is very clear. And can you just elaborate a little about the weaning of this high flow? What should be the method we should follow?
Yeah, again, so high flow means high flow. So we have discussed about the physiology behind high flow. So we need high flow to get all these effects. So no point using high flow machines with low flow. So in that case, you have to go for low flow oxygen delivery device. So we see now if the child is perfectly all right, the saturation is maintaining even with 21% FiO2, we have to wean from high flow. So definitely we can select some other oxygen delivery device and go for that, rather than reducing the flow on high flow. I know that some of the guidelines in some countries, especially Australian guidelines, are saying you can use 0.5 to 2 liters per kg per minute. But again, we had very good discussions about this in the pediatric critical care conferences. And what most of the people are suggesting, that to get the desired effect, you need at least 2 liters per kg per minute. In some countries, they are using 3 liters. So 2 liters is the minimum. So if you don't want 2 liters, that means if you don't want high flow, go for some other device rather than reducing the flow on high flow. So it won't be high flow.
So, okay, so that is very clear. So we can straight away change over to the low flow, our usual conventional oxygen delivery systems when the need is not there further. Okay, and as we discussed, this mainly pertaining to COVID-19. So management of children with COVID-19, the use of high flow. What is the use of bacterial filters or viral filters in these patients? What is your recommendations? Even Jason also can add to that. Deshan?
So use of bacterial filters in high flow.
Oh, the viral filters, yes. We had one question here.
Okay. So far, we haven't used any viral filters as such in high flow nasal therapy.
Dr. Deshan, Niroshan here.
Hello. Yeah.
Niroshan here, Dr. Deshan. So,
yeah.
Yes, Niroshan.
Addressing the point, so we are using a bacterial viral filter, which is in the backside of the machine. I think as you've seen in the video, the nurse is changing a filter. So that is the bacterial viral filter with an efficacy of 99.99%. So it acts as a bacterial viral filter, and it filters all the room air, the air entering into the device. So that is one of the safe method that we are using to minimize the contamination of the device.
Okay, thank you. Yeah, so if you have any further questions, you can still use. We have a few more minutes. Yeah. So before concluding this, Nalin sir, do you want to add anything or any want to give any take-home messages? I am sure you are receiving many calls during this time period to get some advice about use of high flow. So that is one of the main reasons to arranging this webinar by the PICC of SLCP. Before wind up these sessions, do you want to add anything?
Yeah, because now since we are in the middle of this epidemic, so many people are asking how to deliver the oxygen in these patients. So far, in pediatrics, hypoxemic respiratory failure in COVID is rare. So we are lucky. But at the same time, the numbers are increasing. So even the percentage is low, sometimes the actual numbers may be high in coming time. So we have to be ready. So that's why we have to be ready with this. So I know previously also with the SARS epidemics, we had a lot of high flow machines around the country. So we can use these machines effectively. People have not used them very rarely previously. So that's why we have organized this, because people are calling and asking how to use this high flow machine. So a good example is sometimes some of you may have, they are in the college webinar last week. So there was a patient with COVID-19 pneumonia in Galimada. So we cannot transfer this patient to Colombo. So we didn't have any other option. So we ultimately what we did was we have discussed with the Badulla pediatrician, and we have mobilized their high flow machines to Galimada. And this child was discharged without any complication. So that's the way that the high flow machine has helped. So that is why it is very important. So if anybody wants to improve your respiratory care for COVID-19, I think it's high time to go for high flow machines. People are asking whether to go for high flow or non-invasive ventilation. It's very clear. If you're thinking about COVID, high flow is much better than non-invasive ventilation, because one thing is the patients are very comfortable, and the outcome, it's tested, outcome is much better.
Thank you, sir. So in the absence of any other questions, we don't have questions, but we have many messages that yes, sir.
One message. So this is not about the high flow, because now we are in the middle of the epidemic, because all these participants are interested about the COVID. That might be the reason they are participating in this. The message that I want to give is not the respiratory failure, but the multisystem inflammatory disease in children is going up. So at the moment, we have 4 patients in our ICU. One possible one died in our ICU today. So that's the latest presentation. So be careful. They are presenting with diarrhea, shock, and some features of leptospirosis. So if you have any patients like this, think about COVID, this epidemic. So that's the clear message that I want to give, because that will save life. We have issued the guideline on the management of the MIS-C, and we clearly demonstrated that if you use steroid and IVIG, the outcome is much, much better. So we are so sorry about this child, because the thing is now they are very well grown, about 12 to 14-year children, coming with 2-3 days of fever, diarrhea, and shock. It's very difficult to manage without giving steroid and IVIG. If you give steroid and IVIG, within 1 day, they recover. So be careful, they are coming, and be prepared for this.
Thank you very much, sir. So it's a developing situation, evolving situations, new presentation. So it's very important to keep on have background knowledge as well as early identification and early intervention is one of the most important thing, prevention of this type of unwanted effects, unfortunate events. So it's time to conclude these sessions. I am sure almost 100 participants attended, and video also might be available, and even we can post it in our SLCP website under PICC chapter. I would like to thank Dr. Nalin Kitulwatta as well as Dr. Desha Nadihetty, consultant pediatric intensivist from LRH, MICU of LRH, to arranging this, giving the leadership and sharing your knowledge to manage these children, especially to reduce the morbidity and mortality. So thank you very much, sir and Desha, for arranging this and participating in this, giving you, sharing your experiences with rest of our pediatricians and pediatric trainees. And I would like to thank all our participants, all our attendees. Some of you might not be able to, or a few of even the want to attend might not be have attended because of some other work. So we try to upload this webinar into our college website as well. And finally, I would like to thanks FNP, giving all the supports, technical supports, and providing all the videos and sponsoring this session. So thank you very much. Thank you all. And depending on the requirements, so I'm sure that PICC will arrange more and more this type of webinars to educate you, depending on the developing situations with this COVID-19 situation. So it's a time to conclude these sessions. Thank you very much all. Have a nice day. Thank you.
Thank you.